Hello everyone, good afternoon again. And today I am going to cover the rest of your tuberculosis drugs. Yesterday we have covered rifampicin and isoniazid. Okay. In the first generation drugs, other drugs are we have our ethambutol. Okay. Ethambutol is an bacteriostatic agent, and it acts by inhibiting the synthesis of arabinogalactan. Arabinogalactan is a component of your cell wall, and they inhibit this arabinogalactan by inhibition of arabinosyl transferase, by inhibiting the arabinosyl transferase. So it is distributed throughout your body, and it is except in your CSF. So it is not effective for your TB meningitis. So I will repeat it again. It is a bacteriostatic agent, and it acts by inhibiting the synthesis of arabinogalactan. Arabinogalactan is a component of your cell wall, and how it does it by inhibition of the enzyme called arabinosyl transferase, and it is distributed all over your body except in your CSF. And what is the main problem with your ethambutol? It causes visual disturbances, and that disturbances are dose dependent, and it is reversible also, and it is called optic neuritis. Okay. In malaria, where the chloroquine causes malarial drugs, chloroquine causes optic neuritis. Like in TB, ethambutol causes optic neuritis. So the optic neuritis presents as reduced visual acuity. There will be central scotoma, and mainly the MCQ question point of view is loss of ability to see the green color and red color vision. Mainly green color. Okay, green and red. Remember, green color and red color vision will be impaired. Color, loss of color. And what is the reason for that? What is the reason for your visual defects? It is due to its effect on amacrine and bipolar cells of your retina. So ethambutol will affect your amacrine and bipolar cells of the retina. That is the main problem. Coming to, I will repeat it again. The main problem of your ethambutol is visual disturbances. They are dose dependent and reversible. And main problem with that is optic neuritis, and it presents as your reduced visual acuity, central scotoma, and loss of ability to see the green and red color vision. All of these things are happening because of ethambutol's effect on amacrine and bipolar cells. Remember, AB, amacrine and bipolar cells of retina. And since it causes visual impairment and color blindness, you should not give it in the children. So it is contraindicated in the children because the children cannot able to report yearly visual impairment. So it is contraindicated in the children. And other important side effects associated with ethambutol, it can cause hyperuricemia, and it can also cause peripheral neuritis. And I also told you only the drugs which are safe in the liver failure is only two drugs, ethambutol and streptomycin, because they are metabolized in the kidney. And because they are metabolized in the kidney, ethambutol is metabolized in the kidney, and it requires dose adjustment in case of renal failure. Okay. And coming to the another important drug is pyrazinamide, and it is a weakly bactericidal drug. Okay. We can compare it with isoniazid, because isoniazid and pyrazinamide has similar mechanism of action, and the mechanism of action is same. Isoniazid is active against very rapidly multiplying bacteria, but this pyrazinamide is active against slowly replicating bacteria, then rapidly multiplying bacteria, and it is effective only in the acidic media. That is only effective against intracellular mycobacterium. Okay, it is not effective against extracellular mycobacterium, and wherever there is acidic media, it is very effective. So at the site of inflammation, there will be acidic media, so it is effective at the sites of inflammation. So I will repeat it again. It is an weakly bactericidal drug. Sorry, there is a spelling mistake. Is the weakly. Okay, it is not weakly. It is a WEAKLY. Weakly bactericidal drug, and it is more active against slowly replicating bacteria, and it is more effective in your in the acidic media, particularly in your intracellular mycobacterium and at the sites of inflammation. And it is effective only against your intracellular mycobacteria. I have told you its mechanism of action is similar to the isoniazid, but the exact site is not known. And since it is metabolized in both liver and kidney, the half-life of this drug is very much prolonged in hepatitis and hepatic failure and renal impairment. So you should be very cautious about the dose of this drug in these impairments. And very famous MCQ question is which tuberculosis drug causes hyperuricemia. There are two drugs. One is ethambutol, we have just discussed now, and most importantly is pyrazinamide. And pyrazinamide also causes hepatotoxicity as well. So in 40% of the patient, it causes non-gouty arthralgia. Okay, non-gouty arthralgia, and it can cause hyperuricemia also. It occurs more commonly, but it is usually asymptomatic. And you should not stop the drug if hyperuricemia develops. That is very important point as clinical point of view. And it can cause hepatitis. All of the first generation TB drugs can cause hepatic dysfunction. Other than that, it can cause porphyria and photosensitivity. Okay, so coming to the, I will repeat it again. It can cause your non-gouty arthralgia, hyperuricemia, hepatotoxicity, and porphyria and photosensitivity. And coming to the streptomycin, it is also this is tuberculosidal aminoglycosides. So aminoglycosides, all of the drug are bactericidal. They can kill the bacteria. And since the aminoglycosides are not absorbed orally, they should be given in parenteral route. So we are giving streptomycin by IM route in this case. Okay, in case of tuberculosis, and it is poorly plasma protein bound. And I have told you the ethambutol and streptomycin, both of them are excreted in the kidney. So in case of renal failure, their half-life is prolonged. And the pyrazinamide, I have told you, is effective against intracellular bacteria. Wherever there is the acidic medium, it is effective. Intracellular bacteria. Opposite to that, the streptomycin is effective only against extracellular bacteria, and it is not hepatotoxic. So ethambutol and streptomycin are not hepatotoxic. You have to remember that point. So other features of streptomycin are similar to the aminoglycosides. And what are other aminoglycosides used for the treatment of tuberculosis? That is a very important question. That is the second line injectable agents. All of these things are all these injectable agents are aminoglycosides. We have amikacin, we have kanamycin, and we have capreomycin. We are giving it in multi-drug resistant tuberculosis, MDR-TB. Okay, and streptomycin is contraindicated in pregnancy. Because of eighth nerve deafness, it can cause in fetus. So streptomycin is your tuberculosidal antibiotic. It is given by IM injection. It is poorly plasma protein bound, and its half-life is increased in renal failure, and it is not hepatotoxic, and it is active only against your extracellular bacteria. And other aminoglycosides used are amikacin, kanamycin, and capreomycin. They are used in your MDR tuberculosis. And streptomycin is contraindicated in pregnancy because of eighth nerve deafness. I have told you, comparing all, ethambutol and streptomycin are not hepatotoxic because they are metabolized in the kidney. So other drugs, now we are going to talk about the second generation drugs in detail. Okay, other drugs we have. Main drug is thiacetazone. Okay, thiacetazone is a tuberculostatic drug, and most of the second generation drugs also causes hepatitis. Okay, every tuberculosis drugs causes hepatitis. There is very dangerous side effect. So if you are giving anti-tuberculosis drug, you have to check the LFT, liver function test, as usually. Okay, otherwise it can land up in hepatic failure, fulminant hepatic failure. So you have to be very cautious about this side effect. And other side effects of thiacetazone, other than hepatitis, is it can cause bone marrow suppression and Stevens-Johnson syndrome, particularly in HIV positive patients. Because of in HIV positive patients, it can cause severe hypersensitive reactions like exfoliative dermatitis. And what is the mechanism of action of thiacetazone? It thought to interfere with your mycolic acid synthesis. So I will repeat thiacetazone again. It is a tuberculostatic drug. It can cause hepatitis. It can cause bone marrow suppression. It can cause Stevens-Johnson syndrome, particularly in HIV positive patients. It can cause more higher risk of hypersensitive reactions, including your exfoliative dermatitis. Mechanism of action is it thought to interfere with your mycolic acid synthesis. And now we have paramino-salicylic acid. So it is related to your sulfonamides like cotrimoxazole. The mechanism of action is similar to the cotrimoxazole. They inhibit the folic acid synthesis. Okay, and it is also a bacteriostatic drug. I have told you all of these drugs are hepatotoxic. Okay, along with that, other side effects of paramino-salicylic acid is it can cause kidney dysfunction also. It can also cause thyroid dysfunction. Okay, paramino-salicylic acid is related to your sulfonamides. It can act by similar mechanism as sulfonamides. Like cotrimoxazole, it is bacteriostatic, and side effects are liver disorders, kidney disorders, and thyroid dysfunction. Now we have ethionamide. Okay, ethionamide. It is another tuberculostatic agent, and another important use other than TB is it is used in leprosy. Okay, keep it in mind. And it can also cause hepatitis. Okay, hepatitis and thyroid problem also, and it also cause optic neuritis. To remember that, we know that ethambutol will cause optic neuritis. So the name starting with E, it can cause optic neuritis. Okay, so ethionamide and ethambutol causes optic neuritis. Remember like that. So it is also used in leprosy. And I have told in previous class, yesterday class, that it has mechanism similar to isoniazid. So it has, and if there is mutation in INHA gene, and there it will be cross resistant to ethionamide as well, because they both share the mechanism of action, similar mechanism of action. And another important drug is cycloserine. The cycloserine, it is a cell wall synthesis inhibitor. Okay, it will inhibit your cell wall synthesis in mycobacterium, and it can, main important side effect they can ask in your MCQs is it can cause neuropsychiatric adverse effects. So you have to treat with pyridoxine also to prevent the neurotoxicity. Like in isoniazid, you have to give prophylaxis of pyridoxine, vitamin B6. Another important aminoglycoside drugs in second generation antitubercular drugs is kanamycin and amikacin. They are injectable aminoglycosides which are used in the treatment of MDR tuberculosis. And capreomycin is also belonging to aminoglycoside. It is an injectable polypeptide. It can cause ototoxicity, nephrotoxicity, hypokalemia, hypomagnesemia. This nephrotoxicity and hypokalemia, hypomagnesemia, it occurs also in amphotericin B toxicity. Okay, nephrotoxicity, hypokalemia, and hypomagnesemia also occurs in your amphotericin B toxicity. So, including that, you should add ototoxicity for this capreomycin. So, capreomycin is our injectable polypeptide. And what are the fluoroquinolones we are used for the MDR tuberculosis? We have ofloxacin, we have moxifloxacin, and we have levofloxacin. So since we are using MDR TB, these antibiotics should not be started as first agent in any other infections. Okay, you should reserve it for your MDR TB because they are very highly sensitive for your MDR TB. So you should avoid these drugs as first line therapy. For example, if you have skin infections, if you have pneumonia, you should not start with levofloxacin. You should try alternative antibiotics like doxycycline. Broad spectrum antibiotics you have to start. And these fluoroquinolone antibiotics are also effective in your mycobacterium avium complex, okay, in AIDS patient particularly. And newer macrolides like your azithromycin, clarithromycin, they are also effective against your non-tubercular atypical mycobacterium. The drug of choice for your non-tubercular atypical mycobacterium, in the mycobacterium avium intracellular complexes, clarithromycin and azithromycin, along with rifabutin. Okay, rifabutin along with ethambutol. We call it as REC. Okay, REC means rifabutin plus ethambutol plus clarithromycin or azithromycin. And coming to the rifabutin, I told you it is an analog of rifampicin, which is a derivative of rifamycin. Okay, rifabutin is more effective than rifampicin against your mycobacterium avium complex, intracellular complex, because it has very long half-life of around 45 hours comparing to your rifampicin. Rifampicin has just 3 to 5 hours. And comparing to rifabutin and rifampicin, rifabutin is more active against your MAC. Okay, remember that point. And clarithromycin and fluconazole, they are enzyme inhibitors. Okay, so they inhibit the hepatic metabolism of rifabutin, so and increase their half-life of your rifabutin. Okay, and comparing to rifampicin, I have told you it is not a very potential. It is not a potential enzyme reducer. It has less potential to induce your microsomal enzymes. That's why it is very safe, particularly in your anti-HIV drugs, in particular in HIV patients, those who are receiving nevirapine, protease inhibitors, and NNRIs. So in HIV patients, you should give rifabutin in place of rifampicin. And what are the side effects of rifabutin? Rifabutin can cause your gastrointestinal side effects also. Rarely, it can cause your anterior uveitis, hepatitis, Clostridium difficile associated diarrhea. It can cause diffuse polymyalgia syndrome. It can cause yellow skin discoloration that we call as pseudojaundice, and it also causes pancytopenia. We know that rifampicin is metabolized in the liver. So, but rifabutin, it is not metabolized in the liver, so it does not require dose adjustment in liver disease like rifampicin. So it is one of the advantages comparing to the rifampicin. So rifabutin, the adverse effects are gastrointestinal side effects, anti-uveitis, hepatitis, Clostridium difficile associated diarrhea, diffuse polymyalgia syndrome, yellow skin color discoloration called pseudojaundice, and pancytopenia. What about rifampicin? Can we use it in case of tuberculosis? Definitely no. What is the reason behind that? Because it is similar to rifampicin, but it is more lipophilic and longer acting. And what they have seen is it is not approved for administration to patients with HIV disease because of higher rates of relapse. So you should not use in such cases. And only drug approved is rifabutin only. Okay, and the absorption of your rifampicin is increased with meals, so you should take with meals if you are giving it other infections wherever it is indicated. And very important drug is bedaquiline in case of MDR-TB. And what is the mechanism of action is it inhibits your mycobacterial ATP synthase, so energy production will not be formed and bacteria will die. Simple mechanism. And it is indicated as a part of MDT multi-drug therapy in adults with pulmonary MDR tuberculosis. The main side effect associated with this, it can cause increase in your QT prolongation. So this is the very dangerous side effect. They can ask this question in MCQ also, QT prolongation. Okay, so bedaquiline inhibits mycobacterial ATP synthase. It is used as a treatment part in pulmonary multi-drug resistant tuberculosis, and it can also cause QT prolongation. And what about rifaximin? Rifaximin is different from they are rifampicin derivative only, but they have no use in tuberculosis. Only there are two indications for rifaximin, that is traveler's diarrhea in E. coli and hepatic encephalopathy. Okay, you have to remember these 2 points as well. Rifaximin is indicated for traveler's diarrhea, E. coli, and hepatic encephalopathy. It has no use in tuberculosis. The only two drugs are used in tuberculosis, that is rifampicin and rifabutin. Okay. Isoniazid and pyrazinamide, they have the maximum CNS penetration. And if you talk about ethambutol and streptomycin, they do not cross your blood-brain barrier, so they have no effect in TB meningitis. So you should not use ethambutol and streptomycin in case of TB meningitis. So other drugs we can use, because if you talk about rifampicin, it has moderate CNS entry. Okay, so these drugs can be used. H, Z, or that is isoniazid, pyrazinamide, and rifampicin can be used in TB meningitis because they have very good CNS entry. Now talking about the definition of MDR tuberculosis. What do you mean by MDR tuberculosis? MDR tuberculosis means the resistance to minimum isoniazid and rifampicin. So both. If the tuberculosis is resistant to isoniazid and rifampicin, it is called MDR tuberculosis. Then what is XDR tuberculosis? It is defined as resistant to both the drugs isoniazid and rifampicin and all fluoroquinolone agents. What we are using in fluoroquinolone agents, we have ofloxacin, levofloxacin, and moxifloxacin. So if they are resistant to that, and at least one injectable agent. So what injectable agent we are using? Capreomycin, amikacin, and kanamycin. So any of one injectable agent. So coming to the definition, if it is resistant to minimum isoniazid and rifampicin, it is called MDR-TB. And if it is resistant to both of them, all fluoroquinolone agents, and at least one injectable agent, that is called XDR tuberculosis, which is dangerous comparing to MDR. Coming to the therapy of tuberculosis for new case or old case, nowadays it is the same regimen. Okay, so intensive phase, that is 2H or ZE. We are giving all the 7 days. Okay, all the 7 days per week. Previously it was intermittent regimen, only thrice weekly. It's not like that nowadays because of relapse and failure rate is increased. So we are giving nowadays a daily regimen therapy. Okay, so we have 2HRZE in intensive phase. And in continuation phase, we are using 4-HRE. The 2 is for months. Okay, 2 plus 4 equal to 6 months. So we are using such therapy. And pyrazinamide we are not using in continuation phase. Okay, so 2-HRE plus 4-HRE, 7 days per week. And coming to the treatment for MDR tuberculosis, we also have intensive phase and continuation phase. So I make it as easy as POCKEE. Okay, POCKEE. Okay, what is P for pyrazinamide, and O for it is levofloxacin or ofloxacin. Okay, remember that ofloxacin or levofloxacin. C for cycloserine, and K for kanamycin. So you should give at least one injectable agent, that is kanamycin, and E for ethionamide, and E for ethambutol. So two E's are also used here. So we are giving for 6 to 9 months. Okay, and in continuation phase we have to give all of these things except K. Okay, except K. So it is we are giving it for 18 months. So totally 6 plus 18 equal to 24, and 9 plus 18 equal to 27. 24 to 27 months we are using this drug. So your Poki, it is a very common term like Pokiri. Remember Pokiri? It's a Vijay's film. You don't know that Pokiri. So it's called Poki. Okay, Poki. Remember like that. So P for pyrazinamide, O for levofloxacin or ofloxacin, C for cycloserine, K for kanamycin, E for ethionamide, and E for ethambutol. 6 to 9 months. In CP continuation phase, you have to avoid K. You should get POSI. You have to give only POSI for 18 months. So total duration is 24 to 27 months. Simple. So in case of exterior tuberculosis, what we have to use? It also has intensive phase and it also has continuation phase. Here instead of 6 to 9 months, we are giving 6 to 12 months, and continuation phase we are giving for 18 months. Okay, and totally it is 24 to 30 months. So what drug we are using? We are using capreomycin. We are giving moxifloxacin. We are giving PAS, that is paramino salicylic acid, and we are giving high dose isoniazid, high dose H. We are giving clofazimine. We are giving linezolid, and we are giving amoxicillin. And in continuation phase, you just take out the capreomycin. That's it, and you have to give all other drugs. So these drugs should be given for 24 to 30 months. So I will repeat it again. For exterior tuberculosis, we are giving 6 to intensive phase 6 to 12 months, capreomycin, moxifloxacin, PAS, high dose H, clofazimine, linezolid, amoxicillin. In 18 months, you have to take out the capreomycin and you have to give the drug for 18 months. So total duration comes around 24 to 30 months. So nowadays there is a new treatment for exterior tuberculosis. What is that? We have to give just only for, instead of giving 24 months, we have to give for only 6 months. These three drugs. Okay, remember that BPL, below poverty line. Remember like that. So bedaquiline and pretomanid and linezolid. BPL, below poverty line, bedaquiline, pretomanid and linezolid, just for 6 months. That is enough. And only indication is exterior pulmonary tuberculosis. It is not used in extrapulmonary tuberculosis or latent tuberculosis. And you can also use it in MDR tuberculosis if they cannot tolerate normal regimen for 18 to 24 months. In such cases, MDR TB, then you can use these three regimens: bedaquiline, pretomanid, and linezolid for 6 months. Coming to the atypical treatment for atypical mycobacterial infections, we know that I have told you that the drug of choices are easy. Remember, rifabutin, ethambutol, and clarithromycin, azithromycin. So the clarithromycin and azithromycin is recommended for prophylaxis of your MAC infections with CD4 count less than 50 international units. Okay, so the treatment comprises of REC regimen, that is rifabutin, ethambutol, clarithromycin, and azithromycin or azithromycin. If you talk about only the azithromycin, it has very long half-life. Okay, so once weekly dose is enough. Okay, in place of clarithromycin. If you want to give clarithromycin as prophylaxis, you have to give daily. But if you want to give azithromycin, once weekly dose is enough because of long half-life. And what are other drugs effective in case of atypical mycobacterium? I have told you quinolones are effective. Ciprofloxacin, levofloxacin, moxifloxacin, other gatifloxacin also. Along with that, one aminoglycoside is effective, that is amikacin, is also effective for your atypical mycobacterial infections. From this, we finish this entire tuberculosis class, and next class we will talk about leprosy. And thank you for your kind attention.